So my presentation is about pancreas elastography. So I'll discuss a bit about only the elastography part of pancreatic endoscopic ultrasound, and this is how endoscopic ultrasound evolved during time. So it started with mechanical radial transducers, then it moved forward at the beginning of the 90s with linear transducers, and then from 2005 we had elastography on the market, and it's a strain elastography only for endoscopic ultrasound. There are a few studies on shear wave elastography showing up, but there aren't too many studies with transabdominal ultrasound. So most of the literature is with endoscopic ultrasound, but there are more and more studies with transabdominal ultrasound. And the problem with focal pancreatic masses is that although we can do fine needle aspiration, the sensitivity of the method is not perfect. So even if we puncture these focal pancreatic masses, the sensitivity is around 85% with fine needle aspiration, and the specificity, although the specificity is close to 100%. But nevertheless, we need imaging as well to characterize these focal pancreatic masses. So fine needle aspiration is not perfect, although with new fine needle biopsy techniques, we get more and more accurate diagnosis. So the sensitivity can go up to 95 or even 100%. Then these are the methods that can be used with focal pancreatic masses. So we need both elastography and also contrast enhancement, sometimes 3D techniques, and maybe fused images with CT and MR. And this is how the principle of elastography, of strain elastography, works. I think you are all aware on how it works. So basically, whenever you have compressions of the tissue, then soft tissue is easy to strain and hard tissue is hard to strain. So basically, tumors which are hard to strain will show up differently. And this information is translated, so you have a color scale which is quite similar. The color scale is quite similar with the Doppler examination. The only difference is that it's color coded, starting with red, yellow, green, and then going to blue. So basically, if you have inclusions which are very soft, then you will see a green pattern. If you have inclusions which are very hard or stiff, then you will have a blue pattern. And this information can be quantified. This is how strain elastography works. This is the most used system, as Christian mentioned, so is the system which is the most used with strain elastography. I don't want to enter into too much technical details, but basically this kind of compression information is translated into an elastography map. So basically, if you have a stiff inclusion, then it will be color coded, and this information will be overimposed on the grayscale information. But there are some problems with elastography and a lot of artifacts. So basically, if the region of interest for elastography is too small, then you get artifacts. So basically, you have to cover at least 50% more than the lesion which you are trying to image. Then the degree of compression is important. So these are two types. There is a press indicator in the older systems, and the best compression should be 3-4. So whenever you have this press indicator showing up 3 and 4, then the compression rate is good. But sometimes this is difficult to be controlled with endoscopic ultrasound, and you need you cannot control it with a transducer. So then we had in the newer systems we have strain graph display. So this gives an improved operator feedback, and you can examine if the compression was uniform. Then it's easier to select the optimum frames for analysis, and you can remove the operator bias. So Basically, this is how elastography works. This is an example of thyroid. Sorry. So it's an example of thyroid. So basically, you do the compressions manually. So whenever you do the compressions manually, then you see it's a bit sinusoidal. You can do this with your hand with manual compression, but you cannot do it with the endoscopic ultrasound probe. However, this is the perfect situation. When you get compression and decompression of the tissue, then you can go move your pointer back and forward, and you can select a good frame for the elastography. And this is usually when you release the tissues, so during the decompression phase. Then you can average several elastography images, and you can get an average image, and then you get rid of some of the artifacts. This is how a stable compression looks like. So this is an optimal examination where you get stable compressions and you get this sinusoidal curve. The compression is really small, so you need to compress only 1%, not too much. Whenever you have unstable compressions, then it's not proper and you can get a lot of artifacts. And sometimes you need to select your best image automatically. So you just move back and forward your point of interest, and then you select your best image during the decompression phase. Then you can also quantify this information on strain elastography. This is an example of strain ratio. So you have two regions of interest. One is inside a pancreatic focal mass. The other one is either at the same level, or some authors use the second region of interest here on the GI tract wall. However, this induces a lot of artifacts, and we prefer to use the histograms. So you have inside a region of interest of elastography, you have a smaller region of interest, and this one, which is smaller, it's inside of the tumor. So here it was a pancreatic adenocarcinoma, and you see the region of small square region of interest inside the tumor, and you see the strain histogram. So you can measure the average strain histogram values and also the standard deviation. And I already mentioned we had a question about the standard deviation. So the standard deviation is quite small in very stiff masses like pancreatic adenocarcinoma, and the standard deviation is larger in normal pancreatic tissue and also chronic pancreatitis. Then you saw the presentation from Christian. So initially we used this for lymph nodes. This is a benign lymph node on the left image. This is a malignant lymph node, and you can clearly see the difference. So this one was soft with a soft, very soft hilum. This one was hard, so a metastatic lymph node. And you can again quantify this information, and you can obtain a strain histogram, and you can measure the standard deviation and also the average Q histogram or strain histogram values. Then these are examples for the pancreas. So this is the normal pancreas. The image is from the gastric body. So the endoscopic ultrasound probe is placed in the stomach on the body. And then you can examine the pancreatic body and also the tail. And you see these values, and you see the average strain histogram here. So the strain histogram has quite low values. The Q histogram has quite low values, and you see the average values are on green. This is an average image, and maybe it's easier to look at the average images as compared to the movie, because the colors are changing too fast in the movie. This is an example of chronic pancreatitis, and you already see the calcifications. And because of the fibrosis and calcifications, then you see that the image is quite mixed. So you have this mixed appearance with intermediate values. And if you look at the average values of the histogram, then you see that they are more towards the blue. And also the standard deviation is quite high here. Then if you look at a patient with pancreatic adenocarcinoma, then you see that the tumor is very stiff. So you are seeing a blue a lot of blue colors on the average image. And again, if you look at the average hue histogram here, then you obtain high values and you have a very small standard deviation. And we have used these images in our initial study published in 2011, 2012. And you can see in red, there are the pancreatic cancer patients, in blue, the chronic pancreatitis patient. And using a cutoff, we could differentiate pancreatic cancer from chronic pancreatitis, but the accuracy is not perfect. So the area under the receiver operating curve is about 0.85. So it's not perfect, and the method has an accuracy of around 80%. The sensitivity and specificity are around 80%. So it's not perfect, and you won't be able to differentiate pancreatic cancer as compared to chronic pancreatitis. This is how it looks in newer systems. Again, normal pancreas is very soft as compared to chronic pancreatitis and pancreatic cancer. And if you use strain histogram, then you obtain information on the average values and also the standard deviation. Again, average values are high for the hue histogram, and the standard deviation is very small. Then for chronic pancreatitis, the standard deviation is a bit larger. Then if you look at the meta-analysis in the literature, then you will see this is an older one. There is a newer one from 2018. Basically, you will see the same results, very high sensitivity, over 90%, but very low specificity, around 60–70%. And this is because some of the values from chronic pancreatitis and pancreatic adenocarcinoma are overlapping. However, if you look at this, this study, this again showed high sensitivity, low specificity. So the authors actually questioned the value of elastography, but they also mentioned that it should be used in combination with contrast study. So this is quite important, that you should use a multiparametric and endoscopic ultrasound or ultrasound, and you should use all information available. However, if you want to use only elastography, this is quite useful in very small pancreatic lesions. So if you have lesions less than 15 millimeters, in this study with over 200 patients, then the negative predictive value was almost 100% for pancreatic adenocarcinoma. So if you have a soft lesion, soft small lesion on elastography, then it's definitely not an adenocarcinoma. Then we will probably see a lot of newer techniques. This is an example of transabdominal ultrasound elastography, and it's a 3D reconstruction. We're not sure if it's going to be helpful, but maybe in haptic devices like this one, then you will have an opportunity to feel and maybe palpate stiff structures like focal pancreatic masses. Then again, it's really important to use contrast as well. And if you have this combination for pancreas, so if you have a hypo-enhanced lesion on contrast, which is very stiff, then you are probably very confident that it's a pancreatic adenocarcinoma. And we have tried to look in patients with negative EUS-FNA, and then the specificity is almost, and the negative predictive value is almost 100% if you have these two combinations. So either a hard mass on elastography with hypoenhancement on contrast, or the opposite solution, soft mass with hyperenhancement. So in these two situations, you can use contrast and elastography to derive more information if the final aspiration biopsy is negative. And we have recently proposed this algorithm. So if you have a mass hard on elastography, you do contrast, and then you can choose your needle, either a cytology needle, or if the mass is hyper-enhanced on contrast, and if you suspect an autoimmune pancreatitis or a chronic pseudotumoral pancreatitis, then you change to a biopsy needle. So you can pick your needle according to elastography and contrast enhancement. And moving towards the new guidelines, which will appear quite soon this year, these were our conclusions, the conclusion of the panel of experts. So first of all, that both transabdominal and endoscopic ultrasound may be used as additional tools for the diagnosis and grading of chronic pancreatitis. Then another recommendation was that endoscopic ultrasound elastography can be used as a complementary tool for characterization of solid pancreatic lesions. However, it cannot decisively differentiate focal pancreatitis and pancreatic carcinoma. And the last recommendation is that whenever you have a combination of elastography with contrast studies which suggest pancreatic cancer, even though the biopsy is inconclusive, then you should repeat sampling or send the patient directly to surgery. So these are the three recommendations which will show up in the newer version of the EFSM guidelines. That was the presentation. Thank you very much. So I'll try to check briefly if there are, I think there are some questions. Let me check if there are some questions. Okay. Yeah, so the first question relates to grading or staging of chronic pancreatitis or diagnosis of early chronic pancreatitis. So there is one study from the group in Spain where they tried to stage chronic pancreatitis according to strain ratio. And according to strain ratio, they could define different degrees of pancreatic insufficiency and fibrosis. But I think we need more data. So there is, I agree with the question. So there is one study looking specifically on the grading, and you can do this with either strain ratio or strain histogram. So you need some form of quantification. And then the second question, I think I have explained this. So for the differentiation of pancreatic focal masses, for the differentiation of benign and malignant, elastography again is useful for small pancreatic masses. Whenever you have a soft mass, then you are pretty sure that it's not adenocarcinoma. So the negative predictive value is 100%. So I think this is the role of elastography in small pancreatic lesions. Otherwise, you need to use it together with contrast enhancement, and then it will also give you information about the differentiation of benign and malignant lesions. So I think those were the questions. So if there are no more questions, then I will introduce the last speaker.